So I now want to move to another drug that is undergoing regulatory review for relapsed and refractory diffuse large B-cell lymphoma, and that is selinexor. This is an agent that has a somewhat different mechanism of action and is approved in some subsets already in myeloma, so some of the audience may be familiar with it there. But Nathan, tell us a little bit about why selinexor might be a reasonable target or reasonable agent for this patient population and the data supporting its potential use.
Yeah. So this is a kind of a new class of drugs, and it's not anything that I think we have for large cell lymphoma, or actually for really any other cancers. It's called a SINE, or a selective inhibitor of nuclear export, and it targets certain proteins that are exported out of the nucleus that give cells a kind of a pro-survival advantage. So it is not necessarily specific for large cell lymphoma, but it targets a mechanism that large cell lymphoma probably uses to keep itself alive and potentially resistant. The drug is oral. It's a single agent. It's associated with some unique side effects. A lot of those have been GI, but we've seen now some fairly decent size phase 2 trial that was targeting patients that have large cell lymphoma. And this trial looked at a fairly difficult population. Most of these patients had at least 2 prior lines of therapy. Some of them were failing transplant. There were some double hit patients that were involved. And in that study, they saw almost a 30% overall response rate, like things like 28 point something overall response rate, with a complete remission rate of around 10%, which again, is not if you think about CAR T-cell data, et cetera, it's not quite as good, but it's a single drug. It's fairly easy to give, and it is effective, at least in a subset of patients that are pretty difficult to treat large cell lymphoma, including patients that have double hit lymphoma. One thing I really thought was interesting with the drug is that in the responders, we saw actually pretty good long-term responses. In fact, if you look at patients that have PR or better, the duration of response is well over 2 years. So there is a select group of patients that I think do achieve durable benefit with the drug.
So I want to ask Matt and then Cami kind of your either experience with the drug if you've used it, and or your take on reading the literature about it. From the standpoint of kind of the efficacy as well as the safety profile. So Matt, your thoughts?
I have not used the drug in lymphoma. We do have it available in myeloma, as you pointed out. Both, I think we're using it clinically and also in a research setting. My read of the initial paper that was published is it went on an adventure of dose escalation and dose finding and schedule finding, driven mostly by, GI toxicity, as was pointed out. And it kind of like, how could you get enough drug in the subject that they, responded but wanted to stay on it? And I think that over time, if it takes a while, where's the enthusiasm for continued use? So I really think that, if this drug's going to continue to be used, it may have to be with other drugs, if it can be playing in the sandbox, together type of a situation. I mean, we have these novel other agents like tafasitamab, some other oral lenalidomides that where you're seeing this population that there is some longevity. We also should be studying who those patients are that are responding. Even if a small piece of the pie, if we can know who it's worth potentially having those toxicities, and those toxicities can be manageable. It sounds like manageable over time per the paper, but we really need to identify those patients.
Cami, your thoughts and experience?
So I've had experience in a few different ways with the drug, and they've actually been different experiences. So we were involved in the phase 1 study, and as has been mentioned, there was this toxicity, weight loss, fatigue, and those seemed to be problematic. However, once they were able to address and look at appetite stimulants and scheduled antiemetics, we have a phase 2 study in combination with ibrutinib, and it seems to be much better tolerated with the use of these agents now that it's recognized that there are side effects. I think alone the drug is probably not, it's an oral therapy that can be given to high-risk patients, and so it does provide an option for those patients. When you look at the overall responses, I think that Matt and Nathan are right that it's probably best going to be used in combination with another therapy to get the best kind of bang for your buck out of it.
Yeah, I would say we participated in some trials here, and I think that the experiences, as you've cited, that said, when the dose, which kind of overshot and now is settled at a better dose level, it does seem to be better tolerated. And I think it's going to be important for people when they have access to it, if they are considering using it, to really think about the toxicity in the context of the dose they're using rather than kind of the up and down doses that were studied. We have also had a study looking at it in combination with rice chemotherapy and relapsed large cell lymphoma. And interestingly, there was some sense that it may be tolerable, and also obviously would need a randomized trial, but can be given at least with chemotherapy. And I guess what you're seeing with your ibrutinib study as well. So it'll be interesting, and obviously one would need randomized studies for these sorts of combinations. So, Nathan, as you look at this, if you had this available as a single agent, and you had a patient with large cell lymphoma, you have some of the other things we've talked about, CAR T cells, tafasitamab, other kind of standard chemotherapy drugs. Where do you see this kind of used? The nice thing about it is it's an oral regimen that obviously is relatively easy from the perspective of administration for patients to take. So who do you think would be the patient getting single agent, assuming you had access to it and had a patient population?
Sure. So I think that when I think about patients that are failing CAR T, and that's going to be, at least half, maybe more of those patients, I don't have good options for those patients. Generally, I'm thinking about clinical trials. Again, we talked about maybe a Revlimid-containing regimen, but those patients, we're still grasping. And so we often do things like radiation to limited sites, but they don't have a lot of great options that could give them a durable remission. So what I really liked about this is that in those patients who responded, they've got over 2-year PFS. So that to me, I think it suggests that it's an active drug. I don't think this is going to replace auto or CAR T, but still in patients that are failing those kind of approaches, we don't have a lot. And we can do Revlimid, and I think that we'll Revlimid plus CD19, but again, post-CAR T cell failure, to me that's the obvious, or patients that would not qualify, or they're not near a center. That would be the population I would think of.
Cami and Matt, your thoughts? Anything different?
I agree with that.
Yeah,
I agree.